Hello and welcome to week 4 highlights of Advanced Pathophysiology. In the previous week, we talked about atherosclerosis. Now, atherosclerosis produces an increase of smooth muscle cells and increased lipids within the arteries intima, which narrows the blood flow. This eventually affects the entire body and can produce many diseases such as hypertension, renal failure, coronary artery disease, and cerebrovascular accident. Atherosclerosis and atrial fibrillation are prevalent in the United States. The most common cause of death is myocardial infarction, often caused by blood clot formation secondary to coronary atherosclerosis and atrial fibrillation that promotes clot formation. This significantly increases the risk of stroke. Risk reduction in patients diagnosed with acute coronary syndrome includes treatment with aspirin and clopidogrel antiplatelet agent. Patients at risk for embolism due to atrial fibrillation or venous thrombosis are managed with anticoagulants such as warfarin, rivaroxaban, and apixaban. Management of both anemia and anticoagulant therapy is common in primary care settings, which are also the initial identification of many other disorders or red blood cells, disorders of red blood cells, platelets, and clotting. The three major factors contributing to abnormal blood clotting in the absence of frank vascular breaks are endothelial injury, venous stasis, and hypercoagulability. Together, these variables comprise the Virchow triad. Endothelial injury can be a catalyst for intravascular clot formation, particularly in the atrial circulation. The most common context for thrombus formation is fissuring or rupture of an atherosclerotic plaque. Arterial thrombosis often form at the sites of atherosclerotic plaque. Endothelial cells are diseased in the plaque's vicinity, losing their normal thrombotic properties and becoming sites of platelet aggregation and clot formation. In a catastrophic plaque rupture situation, the fibrous cap of an atherosclerotic plaque is prone to fissure and rupture, exposing the inflammatory plaque core and its procoagulant components, including tissue factor. This can lead to a massive thrombus that completely occludes the vessel and causes myocardial infarction and or stroke. Venous thrombi are often formed in blood stasis area, such as the deep veins of the legs. Circulating tissue factor may accumulate here and surface activation of intrinsic pathway proteins to produce clots. These clots may break off and travel through the heart's right side to the lungs, forming pulmonary emboli. The final component of the Virchow triad is hypercoagulability. Many genetic factors like factor 5, Leiden, and autoimmune conditions such as antiphospholipid syndrome predispose the person to hypercoagulability. Still, it is likely that the most common population-wide cause is chronic inflammation. Hypercoagulability is associated with metabolic syndrome, an obesity-related pathological state comprising of hypertension, truncal obesity, dyslipidemia, and insulin resistance. Individuals with chronic inflammatory conditions such as metabolic syndrome and rheumatoid arthritis or acute inflammatory conditions such as influenza or pneumonia are prone to myocardial infarctions. This week we covered neuro and neurological diseases. Stimulation of the venous sinuses, meninges, meningeal arteries, periosteum of the skull, subcutaneous tissues of the head, muscles of the neck, head, eyes, and ears are associated with headaches. Triggers for migraines may include lack of sleep, stress, hormone changes, or particular foods or drinks. Typical signs of migraine headaches include severe unilateral pounding or throbbing pain accompanied by nausea, vomiting, photophobia, phonophobia, and lacrimation. Parkinson's disease primarily involves the loss of dopamine pathways in the brain. Parkinson's disease affects parts of the brain called the basal ganglia. The basal ganglia are important in controlling learned voluntary movement. In Parkinson's disease, a specific part of the basal ganglia called the substantia nigra is affected. Death of dopaminergic neurons results in problems with controlled movement, which leads to the symptoms of Parkinson's disease like tremor, rigidity, and hypokinesia. In Alzheimer's disease, there is a reduce in number of cholinergic neurons in the brain. These neurons are essential in memory. We cannot increase the number of neurons with medication, but we can increase the amount of acetylcholine available at the cholinergic receptors that remain. Acetylcholinesterase is an enzyme that breaks down acetylcholine in the synapse. If this enzyme is blocked with a cholinesterase inhibitor, the neurotransmitters level in the synapse are increased. This might improve cognitive or behavioral symptoms such as memory, motivation, and concentration. They can also improve the person's ability to get on with daily activities such as washing, dressing, eating, and drinking. For some patients, this improvement is maintained for a time, usually about 6 to 12 months, before declining again. There may be no obvious improvement for others, but the current level of functioning is maintained for a period before declining. In others, the drug has no noticeable effects, and the person continues to decline. Disorders of the myelin sheath, demyelinating diseases such as multiple sclerosis and Guillain-Barré syndrome demonstrate the vital role myelin plays in a nerve conduction. Guillain-Barré syndrome is a virally initiated autoimmune disorder that causes demyelination of peripheral axons. It has more motor than sensory manifestations, although patients may complain of pain in addition to motor deficits. There can be a weakness, clumsiness, and hyporeflexia. The general presentation is that of a lower motor neuron lesion. It can progress from lower limbs to the proximal spinal cord, and a patient may need mechanical ventilation. It generally resolves spontaneously and without permanent sequelae. Multiple sclerosis is an autoimmune disorder that causes demyelination of central pathways and tracts. Findings often follow a relapse-remitting pattern, but it does not regress permanently. There are widespread manifestations involving cranial nerves, sensory function, and motor function. Motor manifestation overlap with upper motor neuron lesion, with weakness of voluntary movement, ataxic gait, increased tone, hyperreflexia, and spasticity. MRI may identify plaque-like lesions, particularly in white matter. Patients complain of pain that waxes and wanes and that does not follow a dermatomal pattern in fibromyalgia syndrome. The pain tends to be exacerbated by physical exertion. Depression is thought to occur when serotonin and norepinephrine activity in the brain is low. The management of major depression disorder is aimed at increasing norepinephrine and serotonin activities in the brain. Spinal shock may occur after injury to the spinal cord and can last from a few hours to a few weeks. The symptoms below the injury level include flaccid paralysis of all skeletal muscles, loss of all spinal reflexes, loss of pain, proprioception, and other sensation, bowel and bladder dysfunction with paralytic ileus, and loss of thermoregulation. This concludes the week 4 highlights, and I will see you in week 5. Thank you very much, and good luck on the exam. That's all day tomorrow, Monday. 24 hours is open, and good luck. Thank you so much for listening to this video. Thank you. Have a good evening.